immunocompetent patient, even though there is a CT scan suggestive of fungus, even though BAL galactomannan is positive, it was not fungus. It was another etiology, tuberculosis in this case. What the first case, myeloma, neutropenic, on immunosuppression, grew fungus. Galactomannan was strongly positive in the BAL. Even if that case fungus growth was not present, a myeloma, a cancer patient, chemotherapy, neutropenic, a blood or a bronchoalveolar lavage, galactomannan is more than sufficient to call it as fungal infection and start treatment. The first one, we are right. Second one, even though the fungal marker was positive, it was not a fungus because the patient was not at risk of developing a fungal infection. Everything depends on the patient population. It's very important to take the history. We can't just look at the CT scan or look at the blood biomarkers and call it as a fungal infection. It's very important to do a risk assessment. So these individuals are predisposed. These are typical risk factors for an invasive fungal infection of the chest. And then the CT scan. And then the CT scan. This is a typical, very, very suggestive of invasive fungal infection. See this dense whiteness in the middle and very thin whiteness in the periphery. This thin whiteness in the periphery is called as halo sign. The halo sign, very suggestive of invasive pulmonary fungal infection, especially aspergillosis. But there are many other diagnoses, many other infections, many other fungus that can produce halo sign. Many infections other than fungal infection can also produce halo sign. And later this fungus halo become air crescent sign. And in mucormycosis, we call the reverse halo sign, where the thin halos in the middle and the thickness in the periphery. So these are very suggestive of invasive fungal infection in CT scan. So a predisposed individual with CT scan suggestive of invasive fungal infection, and then look at the a bronchoscopy culture or a CSF culture for brain infection, bronchoscopy culture in pneumonia, and then the galactomannan is useful. A BAL galactomannan or a blood galactomannan more than one, or a combination of BAL galactomannan 0.8 plus blood galactomannan 0.7. So galactomannan is useful if the patient is predisposed for that fungal infection and the radiological features are suggestive. Of course, a culture positivity is very important. If you grow an aspergillus or a fusarium or a scedosporium mucor in a bronchoscopy sample, that's very, very significant. Again, in a predisposed individual, just because you grow a fungus in the BAL doesn't always, a sputum doesn't always mean it's invasive fungal infection. It could be a colonizer in the respiratory tract. Again, it's important to take the history. Important to look at the predisposing condition, the immunocompromising condition. So, because galactomannan, it's a good test, a lot of false positivity, false negativity. That's why the interpretation of the fungal biomarkers is highly dependent on the clinical scenario. We can call it as the pre-test probability. If the pre-test probability for an invasive fungal infection is high, these blood tests like galactomannan and beta-D-glucan, that is another test. Beta-D-glucan is another test for aspergillosis. It's also positive in Candida. Well, galactomannan is positive only in Aspergillus. The beta-D-glucan is positive in Aspergillus, Candida, and even for Pneumocystis carinii pneumonia. You know that, and I'm sure you know that the Pneumocystis carinii, the PCP, nowadays called as the Pneumocystis jirovecii infection, usually seen in HIV patients or immunocompromised patients, it's a fungus. Earlier, it was classified as a parasite. Now it's a fungus. And just like other fungal infections, the beta-D-glucan test is very useful for Pneumocystis carinii pneumonia. In fact, it's with the beta-D-glucan test, even if the blood test is negative, it still could be a fungus. But if the beta-D-glucan is negative, it cannot be a Pneumocystis carinii pneumonia. The negative predictive value is nearly 100% for Pneumocystis carinii, where it's more than 90% for fungus. So it's extremely useful for pneumocystis, and of course, other fungal infections. Again, the pre-test probability is very important. So galactomannan can be used for fungus, especially that's for Aspergillus, beta-D-glucan for Aspergillus, Candida, and pneumocystis carinii pneumoniae. The treatment of Aspergillus is voriconazole. The treatment of mucormycosis is amphotericin B, especially liposomal amphotericin B, or oral agents like posaconazole or isavuconazole. We all know that there are mainly 3 types of antifungals. The azoles include the typical fluconazole, but fluconazole is only active against Candida. It has got no activity against any mold like aspergillosis or mucormycosis. Then we have got the triazole group starting with itraconazole. Itraconazole is active against most of the Candida. Itraconazole is also active against Aspergillus, but not active against a fungus like mucormycosis. Generally, I'm talking in a general principle with exceptions. Then we have got the voriconazole, active against most of the Candida and the drug of choice for aspergillosis, not active against mucormycosis. Then we have got the newer azoles like posaconazole and now the isavuconazole. These posaconazole and isavuconazole are active against most of the Candida. It's active against Aspergillus. It's also active against the black fungus or the mucormycosis, the real technical term. So, itraconazole, voriconazole active against Aspergillus, while posaconazole, isavuconazole active against Aspergillus and mucormycosis. And then we have got the amphotericin group, including conventional or liposomal or lipid amphotericin. They are active against most of the Candida. They're also active against Aspergillus and mucormycosis. Then the echinocandin group, the caspofungin, micafungin, andlafungin, the echinocandin group. They are very active against the yeast form, the Candida. They're also active against Aspergillus, but not active against mucormycosis. So these are the 3 types of antifungals: the azoles, echinocandins, and the polyene group, that is the amphotericin group. The drug of choice for treating aspergillosis is voriconazole. Now, isavuconazole is an alternative option, but voriconazole is the drug of choice for treating aspergillosis. We need to know about the opportunistic fungus. Dear optimist, pessimist, and realist, while you guys are arguing against about the glass of water being half full or half empty, I drank it. That is the opportunist. An opportunist drinks the water when the realist and optimist and pessimist are arguing against whether a glass is half full or half empty. We are talking about the opportunistic fungi. We all know that Candida is a normal colonizer in the mouth and GI tract. It's a normal colonizer in the genitourinary tract. At the same time, it can produce oral candidiasis. It can produce esophageal candidiasis. It can produce Candida vaginitis. It can, of course, produce invasive candidiasis like candidemia or a Candida liver and spleen. For example, hepatosplenic candidiasis, Candida abscess, Candida infected thrombus. So, the same Candida, which is a colonizer, a commensal, become highly dangerous pathogen when it gets an opportunity, because Candida is an opportunistic fungus. What are the predisposing factors for disseminated candidiasis, including candidemia? Broad spectrum antibiotic usage, long lines indwelling intravenous catheters, total parenteral nutrition, GI surgery, thoracic surgery, neutropenia after chemotherapy, low birth weight babies, burns patients, IV drug users, solid organ transplant or bone marrow transplant on immunosuppressant. These are all risk factors for invasive candidiasis and disseminated candidiasis. What is the spectrum? On the mucous membrane itself, it can produce thrush, vaginitis, esophagitis, melanoprostitis. Then skin, different types of fungal infection. The diaper rash, the Candida folliculitis, And disseminated candidiasis, for example, disseminated candidiasis can have skin manifestations. The candida, skin manifestations of disseminated candidiasis. Clinical examination is very important in this context. Then, candidemia, the candidemia, candida in the blood, and deep organ candidiasis, candida meningitis, candida pneumonia. Candida pneumonia is extremely rare. Even if you grow candida in the sputum or bowel, it's not candida pneumonia. If you want to prove candida pneumonia, you need lung biopsy, which is rarely done. So don't make the diagnosis of candida pneumonia based on a sputum or a bowel or endotracheal tube candida culture. Endocarditis. Candida endocarditis is not rare. It's not that common, but not uncommon. Hepatosplenic candidiasis, candida peritonitis in surgical patients, candida osteomyelitis, candida pyelonephritis, candida endophthalmitis or retinitis. This all very important, disseminated or deep organ candidiasis. When you think your patient may be having candidemia, we discussed that. Prolonged hospital stay, broad spectrum antibiotic, lines, GI tract surgery, neutropenic, and high colonization index. That means multiple sites of the body. For example, sputum or urine or wound or drain, they're all colonized with candida. Higher the colonization, higher the rate of candidemia. We discussed that sputum or candida is not a diagnostic of pneumonia. At the same time, it's a risk factor for candidemia. A urine candida is not really, we don't routinely treat it, but it's a risk factor for candidemia. A wound drain candida is a colonizer, but it's a risk factor for invasive candidiasis or candidemia. Now, presentation, fever. In these risk factors, a patient with these risk factors, fever, no localization. Think about candidiasis. Septic shock in a patient with these risk factors, negative culture, negative procalcitonin, and not improving on antibiotic. Think of fungus, think of candida, friends. How do you diagnose candidiasis, candidemia? Blood culture is the gold standard. Whether you can use the usual Bactec bottle or Bactec with special fungal bottle, you don't need special fungal bottle. The usual Bactec bottle is enough, and the yield is very similar. Whether you use the ordinary Bactec bottle or the fungal bottle. The important thing is the blood, the volume of the blood. The most important is the volume of blood. You need to take at least 40 ml, 10 ml, 2 sets, 4 bottles, 10, 40 ml of blood culture. If you take less than this, the yield is going to be very low. Even you take this, the yield is going to be more than 50%. So even if you take 2 sets of blood culture, don't expect a candidemia yield of more than 50%. That is the problem with blood culture. The gold standard, but the yield is low. Then we have got non-culture based method. For example, beta-glucan we discussed. It's positive in Candida, Aspergillus, and PCP. It's good for Candida. But in an intensive care patients, you have to do beta-glucan at least twice a week for early detection of candidemia. It's a good test. It's expensive, a bit expensive, and then you have to keep on doing it to identify a candidemia early. Yeah, the blood culture for candidemia, the gold standard, but the yield is low and turnaround time is more, minimum 2 to 5 days to get a candida in the blood culture. The non-culture based like beta-glucan or PCR are quite rapid, but the problem is especially PCR is not accurate, unlike the blood culture. How do you manage candidemia? The drug of choice for early treatment is an echinocandin. Look, echinocandins cover most of the candida. Fluconazole cover 90% of the candida in India, but not always. It used to be 90%. Now with the emergence of a lot of candida or is in various hospitals, the fluconazole is not the drug of choice for initial treatment of candidemia. You start an echinocandin, wait for the susceptibility and identification of the candida, then change to fluconazole if susceptible. Start an echinocandin, later change to fluconazole if susceptible. The total duration of treatment is minimum 2 weeks from a negative culture. You got a candida in the blood culture. You repeat it after 48 hours. If it is negative, you start counting from that day. So 14 days, 2 weeks from the first negative blood culture. That's a duration of treatment. Any central venous long lines, remove the long lines if you treat candidemia, except in oncology, neutropenic patients where it's a different entity altogether. When to ignore candida? We discussed sputum, tracheostomy, tracheal tube, ET, BAL. Neglect that candida. It's not a pathogen. Urine culture, most often you can neglect. It's only a colonization. But some scenarios you may have to treat. You should never neglect candida in the blood or candida in the sterile fluids like CSF or ascitic fluid or pleural fluid. You treat it, plus give significance to candida. Then we have an entity called as the endemic fungi. Unlike endemic animals, these endemic fungi are not that rare. Endemic fungi are not rare. When to suspect endemic fungi? You are having a patient with fever of unknown origin, or chronic pneumonia, or subacute to chronic meningitis, or skin findings, lymphadenopathy, or something which looks like a TB, but you think you don't have a proof for TB. You think about endemic fungi, or called as endemic mycosis. Something looks like TB, but there's no TB. Think about endemic fungi. Endemic fungi. There are different types of endemic fungi. The histoplasmosis, the blastomycosis, the coccidiomycosis, the paracoccidiomycosis, penicilliosis. Everything depends on the region. These are certain regions are affected. It's always important to take a travel history. Which part of the America you travel, which part of the India you travel, which part of Africa or Latin America you travel, which part of North Asia, Eastern Asia, you travel. Travel history is very important to identify the type of endemic fungus. In India, there are 3 types of fungi endemic mycosis. Number 1, histoplasmosis. Number 2, penicilliosis. Number 3, sporotrichosis. These 3 names we should be familiar. This is the distribution of histoplasmosis in India. Look here, friends. Most of the cases are reported from northeast country, northeast India. That's most of the concentration of histoplasmosis. We had few original histoplasmosis from Chennai, Tamil Nadu, but most of them from northeast, especially West Bengal, Assam, Tripura, Jharkhand. We have one from Tamil Nadu. Presentations, very similar tuberculosis, fever, weight loss, hepatosplenomegaly, mouth ulcer, cough, lymphadenopathy, skin hyperpigmentation, splenomegaly, skin lesions, very similar tuberculosis. Think about histoplasmosis, friends. All granulomas are not TB. Even if the biopsy is granuloma, all granulomas are not TB. TB, yes, necrotizing granuloma. Leprosy can produce granuloma. Fungus like histoplasma, cryptococcus, sporotrichus can produce granuloma. Non-tuberculous mycobacteria can produce granuloma. Brucella, cat's disease, this all produce granuloma. And there are non-infective conditions. Sarcoidosis, Crohn's disease, vasculitis, Kikuchi's disease, hypersensitivity pneumonitis, foreign body, Whipple's. They all produce granuloma. Granuloma is not always TB. Think about alternative etiology. Think about differential diagnosis as well when you see a patient with a biopsy showing granuloma. Now, is histoplasmosis always seen in immunocompromised? No. Histoplasmosis can be seen in immunocompetent people. Yes, some of the studies more common immunocompromised, but there are studies with a lot of immunocompetent patients getting histoplasmosis. How do you diagnose this? Culture and biopsy, typical feature of histoplasma here in culture, and then the biopsy. Culture and biopsy, that's why you diagnose histoplasmosis. And then there is something easy. You can do urine or serum, histoplasma antigen. We do urine histoplasma antigen, very useful test. More than 90% sensitivity for urine histoplasma is antigen for diagnosis of systemic histoplasmosis. And this is our data. When we started doing urinary antigen for histoplasma, our diagnosis of histoplasmosis increased by 3-fold. So it's very useful for diagnosing histoplasmosis. How you treat it? Initial amphotericin B, 2 weeks or 2 weeks of amphotericin B, and later 3 to 6 months or even more of itraconazole. So So initial amphotericin B followed by itraconazole, it could be the treatment of choice in most cases of severe histoplasmosis. This one, this is a different entity. This is the biopsy. A patient, a farmer with the skin lesion, a farmer with skin lesion. This is a biopsy, and the report was sporotrichia, sporotrichosis, typical skin lesion, especially follows after injury, maybe a thorn injury in a farmer, or injury in a farmer, or other occupation. Sporotrichia. Don't forget about sporotrichia, and see the epidemiology of sporotrichia. See North America, South America, few African countries, China, and see the part of the India, the Nepal, and a few northeastern states. So sporotrichosis, diagnosis, culture, and biopsy. Typical sporotrichia lesions in the culture plate. Biopsy, again the typical features. You treat with cutaneous sporotrichosis treated by itraconazole for 3 to 6 months, where systemic sporotrichosis is treated by amphotericin B and then followed by itraconazole for 1 year. Penicilliosis, nowadays we call it as talaromycosis, by a fungus called Penicillium marneffi or Talaromyces marneffi. It's an endemic disease seen in Southeast, Eastern Asia, Thailand, Northeast India, penicilliosis, then China, Cambodia, Myanmar, Taiwan, you get penicilliosis. Fever, weight loss, cough, lymphadenopathy, hepatosplenomegaly. Typical skin lesions. These skin lesions look like molluscum contagiosum lesions. If you have an immunocompromised patient, especially HIV patient with molluscum contagiosum generalized lesions, it could be a molluscum contagiosum, but friends, it could be penicilliosis, otherwise called as talaromycosis. The treatment is amphotericin B and itraconazole. Very important. We have seen plenty of cases of penicilliosis. Now, another patient, a 46-year-old diabetic from Chennai, 7-week history of headache, nausea, fatigability, no other complaints. Neurologist treated it as a migraine, and then the patient had neck stiffness. The blood WBC count was 12,000, 78% neutrophils, no other abnormality. The MRI showed leptomeningeal enhancement. So, of course, it is meningitis, neck stiffness, headache, fever, neck stiffness, meningeal enhancement. It is meningitis. CSF. Opening pressure 25, high. Sugar low, 38. Protein a bit high, 190. The gram stain, AFB stain, negative. 140 cells, 90% lymphocytes in the CSF, expert MTB, negative. So what are differential diagnoses? Yeah, tuberculosis, meningitis, carcinomatous meningitis, aspergillus meningitis, bacterial, partially treated bacterial meningitis. These are all differential diagnoses. But don't forget, do an India in for cryptococcus. This case was cryptococcal meningitis. Now, cryptococcal meningitis is usually seen immunocompromised, isn't it? HIV especially. The patient was immunocompetent. So this is our own series. We had out of 20 patients, yes, 12 were immunocompromised, but 8 were immunocompetent. Immunocompromised, the time to diagnosis was 20 days. Immunocompetent time to diagnose was 90, because people will not suspect cryptococcal meningitis immunocompetent. Please, histoplasma meningitis, the cryptococcal meningitis is a differential diagnosis of meningitis even in immunocompromised, even in immunocompetent. Even immunocompetent, we get cryptococcus meningitis, just like tuberculosis meningitis, just like fungal meningitis, like carcinomatous meningitis. Think about cryptococcal meningitis in immunocompetent patients as well. How do you treat it? We initially give a liposomal amphotericin B or amphotericin B, and later followed by fluconazole. That's a treatment of cryptococcal meningitis. Always common things are common. When you hear hoof beats, first thing of horses, but also consider zebra. First thing of horses, but also consider zebra. All granulomas are not TB. fungus can also produce granuloma. Do keep Cryptococcus as a differential diagnosis in chronic meningitis. Interpret fungal biomarkers with caution. Think about the context. Think about the perspective. Ask for travel history for endemic mycosis. Medicine is an art based on science. The practice of medicine is a science of uncertainty and art of probability. Sir William Osler. Thank you very much.
Thank you so much, sir. It was really very, very insightful session. I'm sure all the participants would have learned a lot of things, and then they would look into all fungal infection in their day-to-day practice. So we will thank you very much. So we will move to the second session of the day, which is emerging and re-emerging viral infection by Dr. Anup Kumar, sir.
Angela, I want to ask one question.
And no, sir, he has to leave. So he has speaker has left.
Okay.
Right. So to chair this session, we have Dr. Ravi, sir, Director of Institute of Endocrinology, Karnataka Institute of Endocrinology, Government of Karnataka. He was the former Director, Dean of Bangalore Medical College and Research Institute, and Professor and Head of the Department of General Medicine. Member of State Authorization Committee of Human Organ Transplant of Government of Karnataka, Past Secretary of API, Karnataka, Governor of CME of Internal Medicine, and he's an avid orator with numerous paper presentation, national and international symposium. Thank you very much, Dr. Ravi, sir, for accepting to chair this session. Over to you, sir, to conduct the session.
Okay. Thank you, madam. Thank you for that kind introduction. First of all, congratulations to the Fever Foundation for conducting this excellent conference, which is very thought-provoking. We just now heard Dr. Abdul Ghafoor on that wonderful talk on fungal infections. Thank for giving me an opportunity to chair this session on emerging and re-emerging viral infections. As you all are aware, we are living in these nowadays with a lot of viral infections which are very common, be it dengue, Zika, plenty of them. Why only these viruses are particularly common in particular regions and particular time. I think to talk to us, there are plenty of these viruses which are emerging and which are re-emerging also. We had the COVID pandemic just recently, which at least we have come out of it. We also heard Dr. Soumya Swaminathan telling yesterday in her introductory remarks, we don't know when we are going to get another pandemic also. So to talk to us on this emerging and re-emerging viral infections, we have got none other than Dr. Anup Kumar, who's the director of the Aster North Korea Kerala Critical Care Unit at the Aster North Kerala. He is earlier the Chief of Critical Care Medicine in Baby Memorial Hospital, Calicut, Kerala. He is the member of the Expert Advisory Panel on COVID Management, Kerala Government. His areas of interest, you can see over there, emerging viral infections, tropical fevers, and infectious disease. We have a very expert in this field of viral infections to talk to us on emerging and re-emerging viral infections. Over to you, sir. I think Dr. Anup Kumar is not in station. Probably his recorded version will be put. I think we'll go through that recorded version. Thank you.
Yes.
Today, we'll be discussing emerging and re-emerging viral infections. This is a very huge topic. As you are well aware, I may not be able to cover the whole topic and may not be able to discuss the full the spectra of emerging or re-emerging infections. So basically, any virus emergence has a continuum. And no specific knowledge of virus will be there initially. Then after that, we'll be knowing a particular clinical presentation. Then the epidemiology of the cases will be understood. From that knowledge, we'll have to isolate the virus from the laboratory. Then diagnostic tests will be available widely. So this is how a new emerging virus will be evolving. And again, any new cases, we'll be having identifying individual cases or identifying cases from the cluster. Then we will have to identify the population pattern. Then we will have to be conveying the information for action, like what are the intervention decisions needed, especially in public health aspect. Obviously, as the cases progress, we'll be having more knowledge about the animal and environmental surveillance, and we'll have to continue with lab surveillance as well. There are many emerging infections from 2003 onwards. There are many, like both viral and other infections. I'm not going into the details about each one of the infections, and I'll be skipping influenza also, because you will be well aware about that. I'll be concentrating on some rare diseases and the diseases which I also have personal experience. So I'll be concentrating on that. And there are many viruses, many viral outbreak reported. This was a paper published from NIV. So we have Nipah, Chandipura, Chikungunya, then Handa, and different other viruses reported already. And it is essential for a clinician to know about the clinical features and diagnostic modalities for these diseases. To start with, we'll start with the Zika virus. We had a recent outbreak in Kerala, and in almost 1 year back, we have reported one case from Calicut. That was a lady who returned from Bangalore. So obviously these cases are there in South India for sure. And a few months before, the cases were reported from Trivandrum as well. This is basically a flavivirus disease transmitted by Aedes mosquitoes. And it can cause congenital anomalies like microcephaly, and sometimes it can cause Guillain-Barré syndrome also. So either we will be evaluating for a microcephaly, a febrile illness, or when you are getting a Guillain-Barré syndrome, we can evaluate and diagnose Zika. It is transmitted mainly by Aedes aegypti and Albopictus, and there may be like a sexual transmission, and there are other pathways also described. And the same mosquito can also transmit yellow fever, dengue fever, and chikungunya. That is why now nowadays we are having a triplet PCR where it can look for chikungunya, dengue, and Zika together. And the symptoms will be almost similar, and there may be a mild difference. The epidemiological triad, like from humans to mosquitoes, and there may be animal reservoir also. And there are many factors, ecological factors, which can trigger the increase in number of cases. The symptoms I have already told. It will last for 2 to 7 days: mild fever, skin rash, joint pain, malaise, headache, etc. A conjunctivitis incidence will be slightly more than dengue and chikungunya. So any patients coming with a hemorrhagic fever features of dengue, where your dengue and chikungunya PCR are negative, and the patients are having a conjunctivitis, you will have to always, or the rashes, you will have to always think about the possibility of Zika. Microcephaly and other congenital malformations, when you detect, in that case also we will have to screen for that. Then, as I've already told, the incidence of Guillain-Barré syndrome, when it is increasing, or when you are approaching a Guillain-Barré syndrome, followed by a febrile illness, you will have to always think about the possibility of Guillain-Barré, Zika virus. The diagnosis is usually with a PCR in the initial phase. Later on, we will have to do an antibody, but antibody can cross-react with chikungunya, dengue, etc. So we will have to see the specific test called plaque reduction neutralization, where the live virus will be inactivated with the sera containing antibody. The treatment is just like supportive treatment like dengue fever. Usually the mortality is also very low. The Crimean Congo hemorrhagic fever is another emerging infection, and this is also having too much international importance. And this is also there in the high priority pathogen list. And the cases have been reported in India also before. And it is basically having like a tick phase. Then from the ticks, it will go to the human infections, and there can be secondary human infections. So this is the usual pattern. And there can be other vertebrate host also, like different animals, including cattle. The clinical features, usually the incubation period will be almost 2 to 14 days, like almost all the fevers. 88% of the infections can be subclinical. That's why you may miss many cases. Case fatality rate is slightly high, up to 15%. The common symptoms will be abdominal pain, arthralgia, bleeding manifestations, bradycardia, thrombocytopenia, etc. So when the patients are having these symptoms with any history of contact with animals, etc., or with history of travel, especially to the African countries, we will have to think about these possibilities. And like many other hemorrhagic fever, it's also having an incubation period followed by pre-hemorrhagic phase, hemorrhagic phase, and a convalescent phase. And sometimes the patient can develop long-term sequelae also. And this is the usual pattern: initial viremia followed by the antibody response, initially IgM, then IgG. And the pre-hemorrhagic period will last for almost 1 to 7 days. And in the hemorrhagic period also, you can see the persisting the viremia here. So the PCR positivity will be possible even in the hemorrhagic period. Many drugs like ribavirin, favipiravir, molnupiravir, and monoclonal antibodies have been tried. Whenever patient is having a severe inflammatory response, steroids also have been tried, and the chances of HLH-like features or macrophage activation-like syndromes are also more in these viruses. So we'll have to screen for that using the scores like H-score, etc. And in that case, we will have to start on steroid. Yellow fever is also an acute viral hemorrhagic disease found in tropical regions of Africa and America, and it principally affects humans and monkeys, and also it is also transmitted by Aedes mosquitoes. And our country is also having this Aedes, both species of Aedes mosquito. And it is having a jungle transmission, then an urban transmission, and an intermediate transmission. And in the urban or in the intermediate the group, the human being can also become affected. Usually the patients will be having fever, headache, then bleeding, vomiting. The renal and liver parameter liver involvement are very common. So it is something like our lepto picture in our area. So whenever the patient is having more bleeding, with almost like a lepto picture, and if the features are not completely fitting into lepto, or your lepto serology is negative, you will have to always think about the possibility of yellow fever also. The same, like you have an infection phase, a remission phase, and an intoxication phase where patient can have the kidney injury, hemorrhage, etc. And here the difference is almost 88% of the patients are asymptomatic, and up to 10% of patients only develop fever, and the mortality is also very less. Then this is another disease, not very rare in our area. It is called Kaisanur forest disease. We usually get patients from the Ghat section, that is Wayanad area. The patients will be coming with features of viral hemorrhagic fever with a history of tick bite. Sometimes there is something like a nymph, a small bubble-like organism. So you can get a history of this tick bite, and the dead monkeys will be noticed in that area. So whenever a patient is coming from these areas with initially fever, then later developing neurological symptoms, coagulation abnormalities, or capillary leak, and if dengue is negative, and more neurological complications, and an early macrophage activation syndrome. So these are the points which we have to always pick up clinically. And if the patients are coming from these KFD prone area, or in the history, if you can get an history that they are near from the forest area or monkeys are there, you have to always screen for KFD. We routinely screen such patients with KFD PCR, and the early macrophage activation is the important complication here, and you have to pick up that using H-score and other parameters, and daily steroid if the patient is developing macrophage activation. And it is not restricted to Karnataka and Kerala as we thought before. It is already being reported from Goa, Maharashtra, and Tamil Nadu also. So these Western Ghat areas, we are getting cases from all these areas. So we should be very careful in clinically picking up and suspecting KFD also. Now coming to the topic of my interest, that is Nipah. As you are well aware, there are almost 6 outbreaks happened in India so far. Initially, we had 2001 and 7. Then 18 for the first time we reported from South India. Then 19, one case was reported from our own hospital in Cochin. Then in Aster MIMS only 2021 case was reported. And this year also we have reported cases. I'll just give you an overview how we have diagnosed. In 2018, we had a male with 3 days history of fever, cough, without any history of travel. And he was having, along with fever, he was having breathing difficulty and altered sensorium. So as he was having the features of acute encephalitic syndrome, he was shifted to the ICU. So while taking the history, we came to know that his brother has died almost 2 weeks back with similar symptoms, respiratory symptoms and encephalitic symptoms. So that time we have asked any other family members are having the similar symptoms. So his father, aunt and the fiancé were also having fever. So they were also got admitted. So they were absolutely normal with low-grade fever when they got admitted. But by evening, they also developed features of encephalitis. And all these patients were having severe tachycardia, hypertension. Then some peculiar neurological features like segmental myoclonus, ptosis, the pupillary asymmetry, segmental sweating, etc. So after all these anti-edema measures, we have done MRI brain and CSF analysis. So these clinical features are very important, like tachycardia, hypertension, abnormal pupils, seizures, segmental myoclonus, ptosis, segmental sweating, dysarthria in the history, cerebellar signs. So if you're getting any of these signs with respiratory or encephalitic symptoms, you have to always screen for Nipah. And this was a MRI finding of our patient. So we did an MRI. It was almost normal and CSF was done. So all 3 patients were having almost normal CSF pattern, but always keep in mind in the previous series also, the normal CSF analysis was reported. So having a normal CSF will not rule out Nipah or sometimes other viral encephalitis also. So here in this case, we had an index patient who died 2 weeks back. The clustering of cases happening and unusual clinical features which we already described. So these things putting together made us to think about some unusual viral syndrome, and we sent the samples to the Virology Institute. And as you can see, we had 5 patients at that time in my hospital, and all these cases, the CSF were negative. And if I was evaluating those encephalitis cases with CSF alone, like I would have missed those cases. So whenever we suspect Nipah, we have to send throat swab and urine also, and CSF is not necessary. And now going back to the MRI picture, you can see this multiple the hyperintensities here, T2 hyperintensities. So this is the characteristic MRI finding. So then at that time we had one patient who was spreading disease to almost 10 cases in a local hospital, including 3 family members. Then in the medical college, when that index patient was admitted, he was spreading the disease to another 13 patients. So altogether, 23 cases were there that time. Only 2 survived, and all other cases died. And another importance of knowing this thing, as you can see, the hospital spread is very common. So we should take all precautions when we are having suspicion of Nipah, or in managing all encephalitis cases. I will say, like, we'll have to take all precautions. In 2019, again, one boy, a 21-year-old boy, was admitted with altered sensorium and fever of 12 days duration. And he had typical MRI findings. This was the typical MRI findings you can see. And the CSF picked the Nipah positivity, and he was treated with antivirals, IVIG, etc., and they could rescue him. And in 2021, in the Aster MIMS Calicut itself, we had one child, 12-year-old child with fever, seizures, focal seizures. He had autonomic dysfunction, and CSF was almost normal, and there was this was a bloody tap. And here again, you can see this multiple T2 small punctate hyperintensities. and this made the clinicians to think about the possibility of Nipah, and they sent the CSF, and Nipah was diagnosed that time, and it was limited to only one case. This year again, we had four persons from the same family presenting with respiratory symptoms, with a history of one family member dying almost 2 weeks back, with mainly the fever, respiratory symptoms, later on developing multi-organ failure. On repeated history taking, we came to know that the initial patient had diplopia and slurring of speech, and the child admitted with the same symptoms developed seizures and features of encephalitis. So now, like, we had an index patient 12 days back, a clustering again happening, unusual clinical symptoms like slurring of speech, diplopia, the neurological involvement in a ARDS patient. Along with that, these patients were from near to the previous epicenter. So putting this all together, again, we had a high suspicion of Nipah, and Nipah PCR was sent. Child was ventilated. Child had features of encephalitis, which you can see here, the brainstem involvement, and again, the other T2 hyperintensities. The child was ventilated for almost 7 days. Ribavirin was given, and we could extubate this child, and that child is having no neurological deficit now. So coming this time, we had one patient initially, and he was transmitting the disease to another 5 patients, and total 6 cases with 2 deaths. So in 2018, we diagnosed the cases from clustering unusual clinical features. 2019, it was cerebellar signs and multiplex PCR, which helped the clinician to detect. In 2021, it was MRI findings and CSF analysis. And now again, the clustering of cases, unusual clinical features, and as they are from the previous epicenter, helped us to diagnose. So you have to always look about the possibility of clustering. Then the symptoms like adrenergic response, myocarditis, stress cardiomyopathy, brainstem signs, cerebellar signs, myoclonus, along with the typical MRI findings, we have to always think about the possibility of Nipah. So this is the encephalitic variety, and sometimes patients can present with influenza-like illness or ARDS. So if your routine viral screening is negative, for an ARDS, you have to always screen for Nipah also. And as per the NIV, the paper, these Nipah viruses are there in almost all states of India, except in some parts of Kashmir. So all the states in India are prone to develop Nipah. And if it was not diagnosed before, it may be missed many times before, and it is not restricted to Kerala alone. And if you screen properly such group of patients, definitely we will be able to pick up more cases. Ebola is also a similar disease. I'm not going into the details. Again, like episodics in animals. Then there is a primary human transmission. Then there is a secondary human transmission. And again, here also, healthcare workers are affected more. The patient can have fever, headache, muscle pain. Later on, vomiting, bloody diarrhea, and the severe hematuria, along with the bleeding from other body openings. So this is a typical feature. And along with that, if the patient is having any travel history or history of contact with the animals, or any other contacts, we will have to think about Ebola. Again, the PCR is the diagnostic modality. So this is another disease called West Nile fever. Again, this was also reported from many states in India. The different flavivirus encephalitis like JE, West Nile, St. Louis encephalitis, and Murray Valley encephalitis can happen. These are having many similar clinical features. In India, we usually diagnose JE and West Nile virus. So this is usually having a like mosquito to like a bird amplifier. Then the human being can be like an accidental host, and sometimes an animal dead host also will be possible. And the JE and West Nile is almost having the similar the transmission pattern. Only thing, the pigs and other animals are involved in JE, but here it is mainly birds. So if you find many dead birds in that area, then you will have to think about the possibility of West Nile. And again, the other, it is mainly by the Culex species. The Aedes usually spread chikungunya, dengue, etc. Here the issue is like only if you diagnose an encephalitis, the incidence of neuroinvasive disease is only 1%, less than 1%. So if you pick up a one case of encephalitis, by that time you might have missed 99 cases of other vaginal fever, because 80% are asymptomatic, 20 will have only mild febrile illness. So one case means it's almost equivalent to 99 cases. Other symptoms like muscle ache, joint pain, etc. It can present with a non-neuroinvasive disease, where it will be difficult to diagnose. And we will be having neuroinvasive disease or encephalitic disease. So especially when the patients are having features of acute flaccid paralysis with polio-like symptoms or polio-like features, we will have to look for vaginal. The same way when the patients are presenting with GBS-like syndromes also, we will have to screen for vaginal. The important thing in knowing the viremia pattern, you can see by the time of symptom onset, the viremia will settle and you will be having only antibody response. So in a symptomatic patient, even if you send a PCR, your PCR will be negative. So you will have to look for an antibody, and this antibody always will be having overlap between JE, dengue, etc. So even if there is a vaginal antibody IgM positive, that doesn't tell you that the patient is having a vaginal. So we will have to do something like these plaque reduction neutralization, which is very specific, or you have to go for an increasing titer in the PRNT. So that will help you to diagnose that. So high index of suspicion will help you to diagnose vaginal. We have diagnosed vaginal fever also before, especially with the high index of suspicion when the patients were having acute flaccid paralysis. So thank you so much. Because of the limited time, I was not able to cover the whole topic, and the personal number and mail ID is given. So any questions in this regard, I will be answering later through the WhatsApp or email. Thank you so much, and thank you Micro team and the FEFCON team for giving me this opportunity. Thank you so much.
Thank you, Dr. Anup Kumar. That was, I think, wonderful. You said in the very short span of time what you had, you have covered the very important emerging and re-emerging viral infections, particularly the Ebola, the Nipah, which you had personal experience. We only doubt why more commonly it is diagnosed in Kerala. Why not others? Probably suspecting the disease is very, very important. Thinking of the symptoms and asking for the investigation and diagnosing it is very, very important to make a diagnosis of these emerging and re-emerging viral infections. Thank you. Thank you. Over to you, madam.
Thank you, Ravi sir. Thank you very much for chairing the session. And thank you, Dr. Anup sir, for an excellent session. We will move to the next session and most awaited session of the day. Today, which is fever in emergency room, diagnosis, red flags, and management by Dr. Rajesh Sharda sir. To chair this session, we have Dr. Shekhar Chakrabarti sir with us. Sir is a senior consultant and he is from the KIMS Care and Research Foundation from Siliguri, West Bengal, and also he is helping us in Fever Foundation activity. So over to you, Dr. Shekhar Chakrabarti sir, to chair this session, sir.
Thank you, Dr. Manjula, for a nice introduction. So thank you, the Fever Foundation, for organizing such a wonderful program on fever and infectious disease. So after having two interesting sessions on fungal infection and viral infections, it is now my task to introduce Dr. Rajesh Chawla, who is the senior consultant and HOD of the Department of the Respiratory Medicine, Critical Care and Sleep Medicine, Indraprastha Apollo Hospital, New Delhi. And he's the past president of Indian Society of Critical Care Medicine and past president of the National College of the Chest Physicians. So Dr. Chawla is the right person to talk on is a fever in the emergency room. You all know that the emergency, how we can diagnose a patient in an emergency room and how will we proceed for the diagnosis and what are the important red flag signs and management. We are eagerly waiting to hear Dr. Chawla. Over to Dr. Chawla, please.
Thank you very much. Good evening, everyone. And thank you very much for invitation to speak on this subject. You see, this subject is very challenging. Whenever a patient arrives in the emergency room with fever, and there are large number of conditions which can really result in fever. And objectives in my talk would be to understand the diagnostic criteria and approach to differential diagnosis, to understand therapeutic strategies, treatment, and prognosis. You know, since we have heard about viral infections and fungal infections, so I will be predominantly talking on tropical infection, which is more common, and the other common infections which we encounter in the emergency room. You know, most of the patients, when they present to the emergency, around 15% approximately visits in the elderly and 5% in adults, people have fever. And usually people will come around second day of illness to the emergency. You know, when I was remembering what I have seen in the last 30 years, the tropical infection would come number one. Then the bacterial infections, predominantly because I am a pulmonologist, so pneumonias, and which could be bacterial or viral, and sometimes abscess. The abdominal infections, which, because after I'm doing now the intensive care, I've seen almost all organ getting involved. You can have the liver abscess, you can have the cholangitis, pancreatitis, diverticulitis, the pyelonephritis, the urosepsis, anything in the peritonitis, post-operative peritonitis, all these abdominal infection can present with fever in the emergency. Then as far as the CNS, meningitis is one of the common conditions which presents with fever, brain abscess. And among, of course, the very sick patients, urosepsis is also very, very common condition which presents patients in shock and in sepsis. And in the cardiac causes, infective endocarditis. Not very common now, but it does present, and sometimes pericarditis. And now we are last about 10 to 15 years, what we are seeing is a large chunk of immunocompromised post-transplant patients, post-chemotherapy patients, because the survival in malignancy is quite high now. These patients presenting in the emergency with fever. And then we have to figure out what kind of infection is there. Then there is a large number of conditions which can result in fever are the non-infectious. The next session, there is a prominent, the intensivists are discussing about this. So I will not discuss, but the various things which can result, of course, the heat stroke, pancreatitis, ITP, DIC, macrophage activation syndrome, massive transfusion, malignant hyperthermia, fat embolism, health, poisoning, particularly snake poisoning, neuroleptic malignant syndrome, stroke, all these are the causes which can result in a non-infectious. So one thing which I feel is common in this part of the world and is the tropical infection. Every year in some seasons you have dengue, some season you have malaria, and you're getting enteric in the summers. So these are the common tropical infections which still we are struggling in our country. Malaria, dengue fever, which is now prevalent, scrub typhus, we now keep on saying. Now probably we recognize more, it must be there always, but we recognize more scrub typhus, enteric fever, leptospirosis, and in winters you always see influenza, and many a times either H1N1, and we, as you know, we had a pandemic of COVID-19 recently. So the challenges, these are the causes. The symptoms overlap. You know, it is not like malaria is different and the dengue is different. The symptoms overlap and difficult clinically to identify these infections at the time of presentations. And you have to start treatment, you have to stabilize them, you have to resuscitate them, and you want to, because they are in, many of them are in sepsis and septic shock, you have to hit wide so that you don't leave anything as you are investigating, and hit early, because we've seen even in a bacterial infection, if you do not treat them early, you do not start the antibiotics within 1 hour in septic shock, and within 3 hours in sepsis, the mortality is more. And then you have to de-escalate once you have the definitive diagnosis. So this is very, very important in these patients. And what I feel is, which is very important, and since I'm going to concentrate more on the tropical infections and the common other infections like pneumonias and others, you need to have a syndromic approach. What group of diseases this is probably lies? Then you have to start the empirical treatment, resuscitate them, stabilize them, investigate, and then once you have the diagnosis, you de-escalate the treatment. So what are the mode of presentation in the emergency room? The commonest is the acute undifferentiated febrile illness. You really don't know, but you try to cover, and many a time patient gets well also, and you really still don't know when the patient is discharged what was the illness in that. Multi-organ dysfunction syndrome, fever with ARDS, fever with thrombocytopenia, fever with jaundice, fever with altered sensorium encephalopathy, and fever with renal failure. So when you, by history and examination, if you can narrow down in one of these syndromes, then investigating them and proceeding becomes easier, and starting the empirically also become. So let's first talk about the acute undifferentiated febrile illness. Usually less than 14 days undifferentiated, fever more than 101. And they have seen that one of the studies, they found that most of the cases, 107 in this study, were non-specific. And of course, the tropical the infections were common. And these are the common causes of undifferentiated febrile illness: malaria, typhoid, HIV, dengue, leptospira, rickettsia, and other viral illnesses. These are the common causes of the undifferentiated. Now, if patient present with fever and ARDS, so it could be infection or it could be non-infections. Bacterial, it could be a community-acquired pneumonia resulting in, it could be viral or bacterial or fungal, aspiration pneumonia. Of course, the tropical infections, dengue, malaria, typhoid, leptospira, they can also cause ARDS. And of course, the H1N1 and COVID-19 here and there, we do see patients presenting with ARDS. And there is a large list of non-infectious causes which cause fever and can result in ARDS: trolley, trauma, amniotic fluid embolism, pancreatitis, poisoning, idiopathic interstitial pneumonia, eosinophilic. Although they're rare, but they can be there, and which can result in fever and ARDS. Now, if the person has ARDS, if you see among the tropical infections, malaria, usually it is a late feature, and leptospira, scrub typhus, and dengue, it appears in the second week of illness. It doesn't occur, but in H1N1, in the first week of illness, patient had a fever for a few days and he will have an ARDS. Then patient presenting with fever with thrombocytopenia. Then here, these tropical infection, particularly malaria, leptospira, dengue, these are the common one which can result in this. And in non-infectious, there are very large number of causes which can result, like TTP, ITP, macrophages activation syndrome, massive transfusion. All these can result in a non-infectious fever. Then fever with altered sensorium. Of course, the meningitis will be the topmost, meningococcal or pneumococcal, then brain abscess, and then sometimes tubercular fever can present TB meningitis, complicated malaria, leptospira. Dengue doesn't cause encephalopathy, rickettsia, and the JE virus, local bleed. Then toxic causes like and metabolic drugs can also result in a fever and an altered sensorium, neuroleptic malignant syndrome, heat stroke, and malignant hyperthermia. So they will cause non-infectious fever with altered sensorium. You know, if you have a fever with altered sensorium and altered sensorium occurs first and then the fever, probably there is a possibility of a stroke, and you need to get a CT and then probably treat with that. But if it is a fever and then altered sensorium, then you have to investigate for the infectious causes. And then patients who does not fall in this category, and you could find out the cause of that, then you have to treat like that. Then fever with jaundice and liver failure. Sepsis, because of any cause, can result in jaundice and liver failure. Hepatotropic virus will come in here. Then of course, all the causes which can result, the tropical fever can result in a fever with jaundice. And among the non-infectious, toxic, metabolic drugs, autoimmune, malignant, heat stroke, ischemic, they can result in fever with liver failure. Now, these are the causes and these are the syndromic approaches. Just to start the discussion in your mind that what I'm going to work at. One thing which I have seen in last 30 years is the most important is, and unnecessary investigation can be avoided, is the detailed history. Never take a detailed history from the person who's brought the patient to the emergency. Ask who was with him, who knows the best about the patient. If the patient is well, then take history from the patient. Otherwise, take from the person, wait for the person, ask them to call that person who knows the best. Because history can give you so much information and which will narrow down your investigations. And then examination. Because if you do not do examination well, then also you can miss and unnecessarily spend a lot of money in investigations. Because fever has a large causes and then you keep on doing investigation without getting a fruitful result. And if, for example, if there is a male fever, dry cough, shortness of breath of 3 days duration, tachypnea, and you know probably I'm dealing with a respiratory, and you do an X-ray and you find pneumonia, probably you know that you are dealing with a, and then you can accordingly go on and test in that patient. Similarly, for if there is a, you are suspecting now and it is falling in malaria, you will have fever with chills and rigors, and they will have the system, all system involvement in these patients. You can have jaundice, breathless, metabolic acidosis, and in that area where the malaria is present, you think probably dengue fever, the saddle kind of fever, and if he's brought some investigation, you will find the hemo concentration, petechiae, and usually the platelet fall down towards when the fever is going. So then you scrub typhus is endemic. Always consider whenever there is a fever with rash, this is most often a misdiagnosis. Now more and more people are diagnosing this. eschar is only present in about 30 to 40% of patients. If you see the differential organ involvement, you know, malaria will have involvement of all organs, but dengue will have liver and platelet predominantly in these patients. Leptospira again will lung, liver and kidney are involved. And similarly, typhoid predominantly liver is involved. So now, as I was saying, there are large number of tests. So unless you take a history and examination, you can just keep on getting. And there are certain tests we always get: full blood count, blood smear, LFT, renal function test, CSF, blood culture should always be sent. And then, you know, rest of the test will depend what is your probable diagnosis. And there are rapid diagnostic tests for available for malaria, leptospira and dengue. Then molecular tests are also available, but used judiciously because they're very expensive. What are you looking for? Just getting a blood test or respiratory pathogens for throat swab is not going to lead you. You will get the report which you will not know how to interpret. What is your diagnosis? What are you thinking in your patient? Then only spend the money of the patient. Procalcitonin can be done in emergency. I feel that many a times it helps you to differentiate between a non-infectious and infectious cause. And imaging will again depend on what is your probable diagnosis, ultrasound, CT, MRI, depending on, and invasive test, again, depending on what you're thinking for. Like malaria now, microscopic rapid diagnostic tests have high sensitivity and specificity. If you have 2 negative rapid test and 3 smear negative, you can practically rule out malaria. Enteric culture is the most important, whether you send a blood, bone or urine or stool, that is more important than serology, which does not have a high sensitivity and specificity. Scrub typhus, again, the eschar and Weil-Felix test, which we know for many years, but now they say if it is 1 in 320 titer, then probably it is specific for an indirect fluorescent antibody, which is the gold standard. And usually we do the ELISA for IgM antibodies and IgG antibodies. Dengue fever, we know that NS1 for the first 5 days, and IgM from 5 to 9th, 10th day, the sensitivity goes from 50 to almost 99%. And this is how the viremia presents in this. Leptospirosis, again, it is a seasonal severe myalgia, and these patients have increased CPK conjunctival suffocation and hemorrhage, with multi-organ failure, particularly kidney is also involved, you think of leptospirosis. The PCR, whether you done in blood, CSF, urine, is very diagnostic in these patients. Serology, MAT test can also be done, and raise CPK level, as I said. Again, the test will always, you should try to do the test what you are looking for rather than just getting a battery of tests. Now, once you have the syndromic approach, you have narrowed down the diagnosis in your patient based on the history and examination, and you resuscitated the patient, then you have to start the treatment. And as far as the fever is concerned, what to give for fever. This is a recent study published in 2023, and they have found the paracetamol 1 gram is the treatment of choice for fever presenting in the emergency. Although they found, this study compared paracetamol with paracetamol and ibuprofen, and they found that probably the first 1 or 2 hours, the combination was better. But I feel because these patients have multi-organ failure, paracetamol is the safest to give in these patients. Then, of course, the drug of choice, if you're thinking of malaria, you will give artesunate, and if it's a pregnant, because then there is choice is clindamycin. Dengue is most often it is supportive treatment. You have to resuscitate the patient, you have to treat the shock, you have to give the fluid, and if there is indications, give the platelets in that particular patient. Scrub typhus, doxycycline is a drug of choice. And there is a study published from India where they found when doxycycline in a severe patient was given along with azithromycin, there was a decreased mortality and decreased hospital stay in these patients. Leptospira, again, ceftriaxone, and along with, you can give with doxycycline. Dengue, of course, it is a resuscitative, and the paracetamol, the treatment. And typhoid, third generation cephalosporin, azithromycin, and quinolones are given for these patients. So how will you approach? A patient has come with fever in the emergency. So first you stabilize like a student, airway, breathing, and circulation, resuscitate the patient, and side by side, somebody is taking the history. The red flag signs in these patients are who are hypotensive, who cannot maintain his airways, who cannot maintain his oxygenation, is very tachypneic. That patient needs to be given immediate attention. Then you have taken a history at examination, and you have identified the focus of infection. And patient has sepsis, then you treat sepsis as per the sepsis guideline. I'll not go into the detail whether it's a pneumonia, pyelonephritis, biliary source, cellulitis. So you treat, and what is the probable organism, and then you choose your antibiotic according to that. And then you send appropriate investigations. But I feel all these patients or infective fever, blood culture is a must, because hardly any, if you've taken appropriately, it is not contaminated, it will give you the answer, make you more confident in de-escalating the treatment. And empirical treatment has been started. That's very easy. Now, you've not been able to identify the focus of infection, but you are able to identify the clinical syndrome. Consider the risk factors, geography, season, and associated symptom, like there is a rash, thrombocytopenia, fever with jaundice, ARDS, Then you send the essential investigation, which I have enumerated, blood culture and all other blood investigation, which I had just sent. And if it is not clear, malaria, because we belong to the area where all these are all the time prevalent. So malaria, dengue, and leptospira, we should send these based on the number of days, whether NS1 would be more appropriate or IgM would be more appropriate. And H1N1, if it is prevalent, you are seeing cases, then you must send that. Then the rapid test has given you the diagnosis. If it's malaria, you treat like that. Dengue, you treat like that. Typhoid, you treat like. If it has not given you treatment, and you think of it as probably a tropical fever, you do not have any other source, you not identify any source of infection, and you feel there is a possibility of tropical, then you need to cover empirically. And what do you give? Ceftriaxone, doxycycline, which will cover scrub typhus and others, azithromycin. This would be the ideal combination in these patients. And then further workup, as you get the report, ultrasound, bone marrow, the serology, and then you de-escalate the treatment in your patients. There are some supportive treatment you have to give in these patients in the emergency, and otherwise, fever with thrombocytopenia, avoid aspirin, give fluids, watch for bleeding, and platelet transfusion. If it is less than 10,000, some people give it less than 20,000, but I think less than 10,000 if there's no bleeding. But if there is a risk of bleeding, even higher, 20 to 40,000 also, and there is no role of steroids in these patients. Then fever with jaundice, then you can give injection ceftriaxone and doxycycline, and watch for the urine output, seizure, and encephalopathy. Depending on whether patient requires the blood products, you need to give the blood and specific therapy once the diagnosis is established. With renal failure, again, you can give ceftriaxone and doxy, and watch for encephalopathy, bleeding, seizures, and renal replacement therapy if required in your patients. With encephalopathy, probably you would like to cover, since till you're diagnosed there, and there is a possibility of viral acyclovir in these patients, along with the ceftriaxone and steroids, and mannitol if there is a suspicion of ICP in these patients. With respiratory distress, again, ceftriaxone and azithromycin. And if you have a suspicion of H1N1, then you add oseltamivir. And watch for impending respiratory failure, shock, renal failure, alveolar hemorrhage, etc. So in last about 20-25 minutes, I've given you it's a large number of causes, large number of conditions which can present in the emergency. History and examination, I think, is the key. We will send all the investigation by knee-jerk reaction, resuscitate the patient well, but not taken the history and examination. A high index of suspicion, good history of examination, and then choose the test which would be most appropriate for that patient. And of course, you have to use multiple diagnostic tests and modalities, and aggressive line of management is required in these patients. And guidelines are only to help you to take decisions, but you have to see that for that particular patient, what would be the most appropriate. Thank you very much.
Thank you, Dr. Chawla, for your wonderful deliberation of how an emergency doctor will diagnose and manage a patient case of fever. So I think all the audience will have a lot of questions, but for the want of time, I am referring to Dr. Manjula, please.
Yes, sir. Thank you very much. Any questions here on the panel? And are there any questions on the platform, RX Events? Otherwise, we can collect the questions and send it to sir for email, and then we will reply to them, sir. Thank you, Dr. Rajesh Chawla, sir. It was really very, very interesting and insightful. I know that what we gave you was a very large topic. You make it very, very nice and comprehensive. Thank you so much. Dr. Chakravarti, sir, thanks for chairing this session with extremely busy schedule of yours. Thank you so much, sir. Thank you.
Thank you very much.
So now we move to the next session, which is the panel discussion on non-infective causes of fever. To moderate this session, we have Dr. Anupam Prakash, sir. Dr. Anupam Prakash, sir, he is the director and the professor of medicine and head of Department of Accident and Emergency at the Lady Hardinson Medical College and Associated Hospital, New Delhi. He's also editor-in-chief of Indian Journal of Medical Specialty, associate editor of API Textbook of Medicine, member of governing body of API, and he's also president of board in the management of Delhi Diabetic Forum, and president of Indian Society of Atherosclerosis Research, vice chairman of API Delhi, and member of advisory board of JAPI, JICM, and Journal of Case Report. And sir has been helping us in all the scientific activity as advisory board member in Fever Foundation. So Dr. Anupam, sir, thank you very much for joining in, and may I now request you take over and conduct the panel discussion, sir.
Thank you, Dr. Manjula. A very good evening to everybody. After interesting sessions, I think we'll move ahead with the panel. May I request Dr. Krishna to please share the slides on my behalf?
Yes, sir. RX event. Neelam, please share the slides.
So we have very eminent panelists right now with us, and I will be posing some commonly encountered queries for them. So at the outset, we have Dr. A.H. Chaudhary, Dr. Anirban Chaudhary, and he is at Director, Professor of Critical Care at GB Pant Hospital, Delhi. And he's an intensivist basically. So we have a whole portfolio. He has a lot many attributes, and he has an expert committee member of a number of institutes, and he has won several awards. And I am sure that we will be enlightened by his presence here. Dr. Chaudhary is one of the panelists. Then we have Dr. Hegde, who all understand. He's again an Hegde's slide. And he is also an intensivist. And he has his training at MRCP Edinburgh also. And he has been attached to Hinduja Hospital. And currently, he's consultant medicine and medicine and critical care, and heading the critical care section there. He's associate editor ICCM, president ICCM Mumbai branch, and he has a special interest in ICU infections with a number of publications to his credit and chapters also. So, Dr. Hegde, again, we will have both the opinions from him from intensivist point of view as well as physician point of view. Next, we have. Can I have the next slide? Dr. Shankar. So Dr. Shankar is again one of the very popular persons we have. He is also on Fever Foundation there. And I have had great experience working with him in the ad board meetings. So he is Professor of General Medicine and Superintendent and Head of the Department at Ronald Ross Institute, Hyderabad. And he is a very academic person, and his inputs have always been very fruitful for us. So we will look forward to have his inputs from the medicine point of view, physician's perspective right now. And then we have Dr. Shaila. Can I have her slide also? She is from the US and infectious disease expert, Dr. Saliha Salim. And she has done her fellowship in infectious disease from University of Missouri. And she is member of American College of Physicians, American Board of Internal Medicine, and American College of Chest Physicians. And she has several publications in index journals. So I have made the presentation like that. We will have the Indian perspective, the intensivist perspective, and the US perspective. So I think with that way, we will move ahead with the non-infectious fever that we encounter in our scenarios. So can I have the welcome all board? I think we can just have are all of them there?
Yeah.
Yes,
Sir.
I think, yes.
Yes, sir.
I can see them. So
Yes.
let us start. If the permission is there, we will start with the session. So can I have the first slide, please? So we have been talking of fever. The last lecture was Dr. Rajiv Chawla's lecture, and we have heard of infectious fever and the thrombocytopenia and all those. So when we talk of non-infective causes of fever, so how common is it? And can I have the next slide, please? So when we talk of non-infective fever, what are the common causes and how common is it? So I will pose the question to Dr. Shankar to give the Indian scenario, Dr. Saliha to give the US scenario, and Dr. Hegde to give, because intensivists will have a different perspective. They will have different causes of fever and how common does it occur. So please, can we begin with Dr. Shankar, sir, please?
Yeah. Generally, what we face in the hospitals also, maybe some functionally they will have some fever, phobia. They will come with fever, but this may be because of some seasonal variation. So completely, sometimes drug-induced fevers, sometimes a vascular psychogenic fever also. Sometimes patient will have a phobia that every time they will feel that my temperature is high. And some endocrine causes also will noted that some thyrotoxicosis symptoms, sometimes some other, they come with some complaints of fever. but generally it is a rare, but specifically we will exclude the infective cause, then we will go for non-infective cause. Generally, these patients are coming with only 2 to 3% only non-infective cause of fever. We can rule out easily because we can rule out by having a temperature chart and history, whether it is related to any other infection by asking history. For example, you ask sometimes a urinary tract infection. You cannot directly any burning in the sensation. So then other fevers, patients are long-standing drugs like steroids, sometimes rheumatoid drugs, autoimmune disease drugs. They will also noted some fevers. So that also you should rule out. You should think of that is non-infective causes. Then accordingly, you have to check the patient's history of past history of drug history or any specific history. Then only we can conclude that maybe this is non-infective cause, and you have to advise the patient. You have to counsel the patient according to the source. Then it will be definitely resolved. That is my opinion.
Well, thank you, Dr. Shankar. Dr. Salim, can we have the US perspective?
Ma'am, she is on mute. Ma'am, can you unmute yourself?
Yes. Can you hear me now?
Yes, please.
Okay, wonderful. My name is Saleha. Hi, everyone, for having me. Yes, so this is a very important question, what are the different causes of it? So first of all, coming to how common it is, I would say it depends upon which setting you're working in, like whether you're in an ICU setting or whether you're in a non-ICU setting. So that also affects, but having said that, I would agree that there is a major chunk that could be just non-infective. And I would agree with what Dr. Shankar said, that you have to make sure it's not infectious before you go down to the non-infectious route. Usually the non-infectious reasons when we start looking into the patient consulted for a fever, we initially have to make sure it's not infection. And once we have ruled that out, then we come to the non-infectious causes. However, there are multiple, I would say, on the list that can actually cause a fever. And as an infectious disease specialist, you should have these in your mind. Even as a general physician, I would say you should have these in mind right on the day one if you see all the signs and symptoms acting up together. For instance, if I'm in an ICU setting, I have a patient who has a major stroke, who has an intracerebral hemorrhage going on and some fever also. So I would keep that in my mind that it could be some central fever going on. If I have to broadly categorize the reasons for non-infective causes of fever, I would say it could be inflammatory process rather than the infectious process, which include all the processes like acute pancreatitis. We have acalculous cholecystitis. Similarly, you can have ischemic syndromes like mesenteric ischemia and ischemia elsewhere, acute limb ischemias that can also cause you have some fever. So basically an inflammatory response anywhere in the body is one of a major chunk, which can lead you to have some febrile episodes without an infection actually going on. The second big chunk comes up if there is some underlying malignancy. That would be an important thing. And it is of note that usually leukemias, lymphomas, malignancy with more of the reticular endothelial lesion, they're the ones who are more likely to cause fever. Besides that, it has also been noticed that usually these malignancies who have like hepatic metastasis, they also tend to be a cause of the fever. Any solid organ tumors can also give you fever as well. So always keep that in mind, that if there's some occult malignancy going on or some malignancy that you're already aware of, might be an underlying cause too. The third thing, although not common, but always keep that in your mind, would be connective tissue disorders, such as any kind of disorders, I would say, whether it's a rheumatoid arthritis, Still's disease, any kind of vasculitis is going on. These should always be in your mind. That this could be a possible thing too. And last but not the least is the drug fever. Although it is said that the drug fever is actually an etiology that should be kept in the last, and it's a diagnosis of exclusion. But at the same time, you should look at the way it presents. For instance, if somebody has a fever and you see eosinophilia and some rash coming in, you should start bringing up the dots together that it could be a drug fever. And especially if somebody is on some particular antibiotics that are notorious to cause fever, which I would say beta-lactams are on top of the list. I would say any drug can cause it, but if you particularly see these notorious drugs like beta-lactams, minocycline, sulfonamides, nitrofurantoin, these are the common antimicrobials that have amphotericin, a very famous cause too, and a commonly used drug. That can definitely lead you to have fever, and not just antimicrobials. Just look and dig into the patient chart. What medication is the patient taking? Anti-epileptic drugs, antiarrhythmics, allopurinol, heparin, a very commonly used agent in the hospital setting. All these can definitely lead you to have drug fever. So I would say, if I have to summarize it, I would say yes, it is common, especially in what setting you're working in. And secondly, if I have to summarize the causes, just broadly, I would do it could be related to inflammatory processes, malignancies versus drug-induced. Thank you.
Well, thank you, Dr. Saleha. That is a very comprehensive answer because it has covered almost all the points of non-infectious fever. But anyhow, we will go forward, and I think the perspective that you have given about mesenteric ischemia and the malignancies, I think that perspective is primarily because you have a greater aging population than our population right now. So we will also be encountering these causes much more frequently in times to come. Dr. Chaudhary, please, if you would like to elaborate upon the ICU setting, when do you suspect, and what is the prevalence or what is the frequency?
Good evening, Dr. Anupam. Thanks for the kind invitation. In the ICU, we usually keep a few factors in mind. Number one, is the fever continuous, or is it coming and abating with time, waxing and waning? Usually, non-infectious fevers are continuous, more continuous. They are low grade. Infectious fever have high grade. Sometimes non-infectious can be of high grade, but it is unusual. And they are usually not accompanied by, like, leukocytosis is not there. TLC count is not that high in non-infectious fever. Moreover, there is something called the temperature and heart rate dissociation, that when the temperature rises by 1 degree, the heart rate increases by around 10 beats per minute. So if that doesn't occur, that is temperature and fever heart rate dissociation, that is more common in non-infectious fever. And most importantly, besides all this, we look for whether the patient is hemodynamically stable or not. If the patient is having hemodynamic stability, lactate is not rising, SCVO2 is normal, PCO2 gap is normal, then probably we think that there may be more of reason to think about non-infectious fever. Otherwise, it may be infectious fever. Although there are contrary views also. For example, acute pancreatitis, despite being a non-infectious fever, we get a high TLC count. In DVT, sometimes we get very low-grade fever, which runs for shorter duration than other causes of non-infectious fever. So minor variations are there. But largely, these are the sources. And whenever we are able to detect, the careful physical examination is very important. Palpation of the lymph nodes, the mucous membrane, just to see and have an idea of whether there is any coexisting disease. So probably these are the common presentations at which we can rule out the infections clinically.
Well, thank you. Thank you, Dr. Chaudhary. It has been what you have covered is very important, and I think it is a very comprehensive clinical perspective. And for each of us who is listening, this is very important to decipher when actually you should suspect a non-infectious cause of fever. And definitely, as everybody said, after ruling out infectious causes, you have to be very careful when you label as a non-infective cause. Can I have the next slide, please? So, Dr. Shankar, this comes to you. What common autoimmune conditions do you think or suspect can cause fever?
Generally, what we face is any autoimmune diseases like rheumatoid arthritis and ankylosing spondylosis, and some other chronic condition like SLE. Maybe they have some fever, but there is no infection anywhere. But they will present like a fever, sometimes 100, 101 degrees. So in that situation, you have to find out that what are the autoimmune disease he is having, what are the medications he is having, whether he is taking regular medicines or not. And most of the time, autoimmune conditions, patient have depression and they have some fever phobia. Whenever there is small cough and cold, when body heats, they will think that some of the, we feel that it is an infection, there is a fever is going on. In that situation, what we advise is, we advise the patient to monitor at home with a thermometer. So without thermometer, patient should not complain that I am having fever. I am always insist the patient. Patient will come, autoimmune disease are 1 month, say I'm 1 month, I am having fever. But if you record at home, temperature will not be raised and temperature will be low grade. As literature says, evening time will have 100 degrees. It's normal only. 1 degree more in the evening because of metabolic condition. And in that situation, we have to ask the patient to monitor at your level, morning and evening night temperature. Then only if it is significantly elevated, then you can think of a autoimmune non-infective causes and you can treat accordingly the disease, whether it is properly treating or any blood counts or variation. And then according to that, if a patient condition is okay, the medicines are regularly, you have to counsel them, you have to assure them nothing will happen. And whatever temperature 100 degrees is normal, then you can think of other diseases, what previously speaker telling that some lymphomas, some other conditions. Sometimes the patient have a trauma, sometimes acute trauma. So there is a inflammation is going on, but they don't know the fall history. But there is automatically some inflammation going on at acute stage and they will have some fever. So generally the autoimmune conditions, fevers are commonly we can encounter, but accordingly we can ask the patient to previous history and ask the patient to whatever medication is taken, then you can rule out when you exclude the fever and accordingly you can advise. That is the main important, because infective cause, rule out infective cause fever is very easier than rule out non-infective cause. What previous speaker is telling, infective cause fevers are moderately high, continuously it will be there, and definitely it is moderate to high grade. Non-infective cause fevers are very lessly, it is progressive, may not be continuous, or it is on and off according to the patient conditions. Patient as the age depends on his psychological and its mental status also, it depends on. So in that situation, we have to counsel a patient with autoimmune conditions, and you can check the follow-up, regular follow-up with whatever their physicians, whichever, then you can counsel them, assure them, and according to treatment schedules, any change of medication in autoimmune condition, you feel that fever is persisting, whether it is drug is what you thought of, any alteration, change of medicine, are tolerable or not, intolerable. Some patient we see, patient is not tolerable to certain drugs. Then he feel irritability and some immune response, and they will feel some fever symptoms also. In that situation, the treating doctor should be closely monitor the treatment of diseases and assure them, and accordingly treat treatment to be accordingly. It will be easier and patient should be happy. That is the one my suggestion.
Well, thank you, Dr. Shankar. So next question is to Dr. Saliha. Can I have the next slide? So you talked of fever, malignancies causing fever. Can you just in brief say how actually malignancies result in fever?
Yeah, so regarding malignancies, like I talked to you about, they're basically lymphomas, leukemias are the top on the list when it comes to fever with the malignancies. So basically, the mechanism of fever for malignancies would be that there is a robust interleukin response and also the release of immunomodulators and cytokines, which all act together. And they are the ones who are responsible for giving fever in these any kind of malignancies, I would say, not just leukemias and lymphomas. So basically, I would say it's an interleukin and a cytokine response that leads to have fever in malignancies.
Okay. So can I have the next slide? So, Dr. Hegde, this goes for you. So, what could be the non-infectious CNS causes which can present as fever? What commonly we should suspect?
Well, first, of course, is patients undergoing major neurosurgery quite often have what's called a post-op fever, or in neurosurgical patients caused a post-jurectomy fever. And this sometimes mimics a nosocomial meningitis, may be sometimes difficult to separate from a nosocomial meningitis. And sometimes people unfortunately get, antibiotics inappropriately, but that is one common cause in patients who have undergone major neurosurgery, just post-op fever or post-jurectomy fever. But the two common causes of fever, especially in patients admitted in the neuro ICUs, either with hemorrhage, subarachnoid hemorrhage, intraventral hemorrhage, cerebral hemorrhage, or with traumatic brain injury, and sometimes brain tumors, are central fever and something called paroxysmal autonomic hyperactivity. So these are the two major causes of non-infectious causes of fever in neurological ICU or patients admitted for a neurological condition. And again, these conditions quite often, patients inappropriately get antibiotics for these two fevers. So it's important to recognize these fevers because you probably can avoid giving antibiotics to these people. Of course, it's important to control this fever because we all know that in neurological patients, fever itself can cause deterioration of the patient's condition. So central fever, we need to separate these two conditions. Central fever, by and large, is seen in patients, especially with hemorrhage, especially subarachnoid hemorrhage or, when intraventral hemorrhage or parenchymal hemorrhage. And usually it tends to be pretty high. It tends to be more or less continuous. There's no fluctuations in the fever. It tends to remain constant throughout the day. There's usually no sweating associated with central fever. And there's inappropriate bradycardia. I mean, there is an amount of tachycardia, but the tachycardia is not proportionate to the height of the fever. So there's inappropriate bradycardia. So that is the other feature of central fever. It generally doesn't respond very well to the usual antipyretics. So generally there is no sweating. So these are and usually it happens after a few early on in the illness of the patient. Usually happens within a couple of days of admission. So it's very unlikely to be infection because it's very, very unlikely somebody with subarachnoid hemorrhage or a brain hemorrhage is infection within day 1 or day 2 of admission. So if they get fever so early after admission, it's more likely to be a central fever. On the other hand, we have something called paroxysmal autonomic hyperactivity, which is seen more commonly in patients with traumatic brain injury. Of course, it can also be seen in other neurological conditions, but more common in traumatic brain injury in the younger people. These patients usually, whereas in central fever, there is usually no stimulus. In paroxysmal autonomic hyperactivity, usually there is some stimulus. Usually a noxious stimulus causes paroxysmal autonomic. So therefore, the fever is by nature obviously episodic or paroxysmal, as opposed to central fever, which is more or less continuous. Is usually associated with a lot of sweating, which is not seen in central fever. There is dilatation of the pupils, which is again not seen in central fever. There is inappropriate tachycardia. So all these things will make you suspect that this is paroxysmal autonomic hyperactivity. So these are the two common causes of, central non-infectious causes of fever in the CNS patients. Of course, other causes, rarer causes are the neuroleptic malignant syndrome seen in patients who get either drugs like haloperidol or other neuroleptic drugs. You can have drugs like serotonergic syndrome, again caused by usually a combination of SSRIs, maybe drugs like linezolid. So these are the non-infectious CNS causes which can mimic infections, but of course should be recognized and treated as such. Sometimes very difficult to treat these causes. Drugs like bromocriptine, baclofen have been tried because the conventional antipyretics don't work in these patients.
Well, great, Dr. Hegde. That was very great of you. You covered it very nicely. So I will come to Dr. Chaudhary now. Dr. Chaudhary, can you please elaborate which drugs could be attributed to as causing drug fever? Although Dr. Shaila just touched it, but I would like to just elaborate upon this drug fever and how to approach such patients.
Yeah. Among the drugs, as Sheila has already suggested, the beta-lactam antibiotics are the ones, the common culprits. We see very commonly with piperacillin tazobactam. We have also seen with cefoperazone sulbactam. With minocycline, we don't see that much, although literature says, but in our experience, when we use minocycline for Acinetobacter, we don't get so much. But besides this, one thing is that meropenem, we don't get. That the one thing, good thing about with carbapenems is that we don't get such kind of, although it's a beta-lactam. Other than the beta-lactams, there are drugs, particularly on the CNS. So we all know that haloperidol and all these are the drugs which often can cause drug fever. And so does amiodarone, which is an antiarrhythmic drug. we know about sulfonamides and all, but we don't use those drugs too frequently in the ICUs, so we don't encounter. But definitely with amiodarone, we do see. And sometimes with uncommon drugs also, like even with our Lasix, who also are diuretics, we have seen patients having drug fever. So these are the common drugs which are responsible for drug fever. Although all drugs can cause, no drugs cannot cause, but it is on our experience, on the basis of the drugs that we use, we can outline these to be the causes in the ICU in particular.
Well, thank you, Dr. Chaudhary. I think that was perfect. And I would just like to add a thing, not to what you have said, but otherwise, there are some characteristics, the drugs have some characteristics because of which they cause drug, like the beta-lactam ring, as you were rightly saying. And there is a component of pharmacogenomics also. So the genetic constitution, so maybe what you are saying, minocycline, although it does have a cyclic ring, which actually causes the fever, but there could be some attributes related to some genetic components. That is why we are not so commonly seeing it. Although tetracycline fevers were known earlier, but maybe it is not being used so commonly and for such a longer duration. So I will come to Dr. Shankar and Dr. Saliha now. So factitious fevers. Now these are very troublesome.
Doctor, one more I wanted to add.
Yes, please, Dr. Chaudhary.
Maybe a long-term use of steroids also have 1 or 2 patients facing a fever. Long-term steroids also, we can think that one.
Okay.
Patient has steroid-induced fever very rarely, but we have reported 1 or 2 cases. Patient have continuously steroids. After that, we investigated everything. Then we tried to wean off the dose or stop the steroids and fever subsided. Maybe one rare cause, maybe you can think of that. A continuous use of steroids also can, whatever other than beta-lactam, what SARS is calling. But you can also think steroids can also cause some drug-induced fever. That is my
I think a very important learning point, because when I was doing my MD, then also I realized that steroids also cause anaphylaxis. So I was very apprehensive. I said, those drugs which are being used to treat and disease, how can they cause allergic reactions? We use steroids, we use antihistamines to treat. But yes, every drug has a potential, and we should also think of steroids as one cause, although a very rare cause. Dr. Shankar, factitious fevers. So how do we go about it? Because they are very troublesome at times. And we have a number of patients at times who present to us with this. So Dr. Shankar from India and Dr. Saliha from US to give a take on factitious fevers.
Yeah, see, generally factitious fevers are very challenging issue for the physician sometimes. So they have to go to actually history wise, and then daily have to detail history, and you have to exclude one by one. And these are common complaints and common symptoms, fevers we are encountered in general OPs. The fever will come, the OP outpatient. Generally, they will come with the outpatient with that. So then we can rule out infective causes, and then sometimes all are negative, but still fevers are persisting, and the temperature charts are various. It's not high-grade fevers. What we feel is the fevers will be persistent 100, 101. It's not associated with sometimes chills and fevers. It's not associated with other symptoms. And then accordingly, the history, the patient presentation and his history, whatever the medicine is carrying, what are the age of the patient, whether he is a professional, what is the profession of his patient, whether it is what is the profession is having, whether hardware or software, and depends on that, we have to exclude and we have to treat accordingly. But these are the physicians will face a lot of practices fevers, but it is, if you find out a proper history and proper drugs history, then you can treat accordingly. It's not much, but it is a very simple exclusion, but we'll forget routinely. That is important, my opinion.
Dr. Saliha?
Yes, this is definitely something to consider. Regarding factitious fever, I would agree with what Dr. Shankar said, that we had to correlate much with the history and examination and all the workup the patient had. Most of the answers is what you're going to get with the history and the examination. For instance, if the pattern of the fever, how high it is, And especially since it also depends how the fever is documented. Sometimes if you are taking like a manual thermometer, there are more chances that they can come up with factitious readings. But with electronic thermometers, the chances is kind of less as compared to the manual ones. So that's another thing that usually helps us monitor the fever better. That if I have somebody coming in over with a factitious fever with some readings, I would definitely hand over an electronic thermometer and would ask them to see how it is. But obviously they can mess with that around as well. But having said that, you have to correlate with the history examination and the workup data. For instance, if somebody says that I've been having fever continuous for the past 1 month, but the CBC looks fine, ESR, CRP is okay, then I would question about the diagnosis of the fever to begin with. And that would be the time when I would start considering about these diagnoses. And also a lot of time, these patients, unfortunately, they have an extensive workup already. And that is another clue that tells you that probably that's going on. Plus, another thing we always look side by side is if there's some secondary gain going on with such kind of things. It's definitely really challenging, both as a physician and also as a patient, I would say. It seems to be like it has some of the patients with a psych history. That's another thing that makes us doubt that it might be having some relation with the factitious presentation that the patient is having. So putting all the dots together, I would say history, past medical history, how is the history correlating with examination and the laboratory test, help us rule in or rule out this thing. But even if you are convinced that it's fictitious fever, I think the next challenging thing that comes up is how to convince the person that it's fictitious fever. That would be another challenging thing too. But yes, if you have a thorough examination and workup there with you, you are able to rule in and rule it out.
Well, great, Dr. Saleha. I think that a component of secondary gain also has to be looked at where every patient who you think has been adequately worked up and has a number of prescriptions and maybe having a factitious fever. So I will move on to Dr. Chaudhary now. So, Dr. Chaudhary, we all understand, especially in intensive settings, at times venous thrombosis and pulmonary thromboembolism can cause fever. In fact, apart from that, even chronic pulmonary thromboembolism patients can have fever, which can be a very prolonged fever. So what is your take on it?
Yeah, that is a very important question and a very important concern for us. But now that we know that this patients with DVT, we are able to identify because we have point of care ultrasound. So we are able to detect this DVT much earlier than we used to do it before. But at the same time, any patient who is overweight, obese, immobile, we know his sedentary habits, having other comorbidities. When we see that there is pain, redness at the site of cannulation or around those sites, there is change in the skin coloration, there is complaining of pain, there are features of phlebitis, then that suggests that there is definitely some amount of phlebitis and there is risk of DVT is high. So whenever such patient is having fever, this fever is usually of short duration, continuous kind of a fever. And the good thing is that it responds very well to the DVT prophylaxis, the DVT treatment. The moment anticoagulation starts, if anticoagulation has not started, then automatically this fever subsides. So that is a very distinct form, and that's the advantage also. But since we start with our thromboprophylaxis measures routinely in much patients much earlier, so certainly the DVT, this has come down, at least in the past decade of our practice in the ICU. But still there are patients in whom, and in those patients in whom it is still very high, we check the D-dimer values, and accordingly we take a decision on whether to change the drug or to increase the dose and like so.
I'll add one more point in this pulmonary thromboembolism.
Yes,
see, sometimes this is the easiest way. Whenever patient comes, you can think of pulmonary causes, but you have the recurrent history. When you go past history, any DVT history, then you can catch hold easily. Some patient will have long back DVT, they have used some medications and some lung problem. So by history only you can elicit, but generally first attempt first time may not be suspected to sometimes permanent thromboembolism. It could be a chronic cause which is having some DVT or prolonged bedridden or any other hormonal tablets or any other clotting. By that history, you can think of pulmonary thromboembolism strongly suspicion, and you can exclude other causes. You can think of fever. But if we view the recurrence only, we can rule out this. That is important by history, recurrent episodes, and past history of any DVT or any medication discontinued. Then you can think of pulmonary thromboembolism can cause this fever. That is you can easily diagnose the
And
cause.
if you can just 5 minutes, you can just place your linear probe onto the femoral vein and once for 2 minutes into the popliteal, I think more than 70-80% of the patients can easily get detected. It's the day-to-day practice.
Yes. So, Dr. Hegde, now I will come to you. What is your take on endocrine fevers? We touched that point just in a line in the beginning. So, what do you think?
Well, now speaking as a physician rather than an intensivist, the commonest endocrine cause of fever, I would think, would be, in fact, probably the commonest non-infectious cause of a PEO is probably be thyroiditis. Nowadays, patients who come with a PEO already have a CT scan of chest and abdomen, and I make it a point definitely to palpate their thyroid, and they wince when you press the particular point of thyroid. That's classically subacute thyroiditis. Of course, these patients may also have some of the signs of thyrotoxicosis. They may or may not have, but I think subacute thyroiditis is probably the commonest endocrine cause of prolonged fever or fever. That's one side, but then that is one. But the other endocrine causes of fever, probably a little more dangerous than subacute thyroiditis, are probably a thyrotoxic storm, a pheochromocytoma crisis, and rarely adrenal insufficiency also can cause fever. Adrenal crisis can cause fever. Now, they say this is not really fever, but really hyperthermia, because the hypothalamic set point has not been raised as happens in fever. Here, the fever is because there's increased metabolism. So there's more production of heat rather than a raising of the set point. So though you're just splitting hairs, ideally it should be called hyperthermia rather than fever. That's of course, that's like I said, most people classical people still call it fever. Now, thyrotoxic storm and pheochromocytoma may probably, because both of them are caused by increased sympathetic activity, the fever, it might be difficult to separate the two. But of course, like I said, they will have tachycardia, hypertension, sweating, dilated pupils, high BP. But a few minor differences maybe might help us separate the thyrotoxic storm. Obviously, we go to the labs and all that to diagnose ultimately. But clinically, in a thyrotoxic storm, by and large, the blood pressure will be a little wide. It will be a wide pulse pressure because systolic will be high, but the diastolic will be low. Whereas in pheochromocytoma, if it's essentially because of norepinephrine, the pulse pressure may not, even both the systolic and diastolic blood pressure might go up. Whereas, in thyrotoxicosis, like I said, it's usually a wide pulse pressure. And many of the pheochromocytoma are generally because of norepinephrine release. And even if it's because of adrenaline release, the blood pressure the pulse pressure is not going to be as wide as it is in thyrotoxicosis. In thyrotoxicosis, the extremity generally will be warm. Sweating will be common in both. The extremities generally be warm. In pheochromocytoma, the extremities may not be that warm. They may be slightly colder because of increased norepinephrine. So these are some of the things that make you, might help you separate pheochromocytoma chrysoma from thyrotoxic storm. Of course, you can look for signs of Graves' ophthalmopathy, which might help you sort of diagnose thyrotoxicosis, one of the causes of thyrotoxicosis. So these are the things that clinically may help you separate thyrotoxicosis from pheochromocytoma. But ultimately, of course, you go to the labs and diagnose. But these are the things you need to consider when somebody comes with what looks like septic, because but of course these people are generally hemodynamically stable, but the BP in fact is on the higher side. These are things you need to consider. The third thing, of course, endocrine cause of fever is adrenal crisis, which this can mimic septic shock because it comes with fever and hypotension. So this quite often, of course, that's missed, is often treated as septic shock because they come with fever and hypotension. Almost everybody with fever and hypotension is treated as septic shock. But these patients generally might have abdominal pain, vomiting, diarrhea, hyperpigmentation. On the labs, you'll have hyponatremia, hyperkalemia, eosinophilia. These are some of the things that make you think that this is likely to be Addison's. Of course, most patients initially will be treated as infection, but culture is negative, nothing, not improving in antibodies. You should think about Addisonian, crisis. So these are the probably 4 common causes of endocrine causes of fever: thyrotoxicosis, pheochromocytoma, thyrotoxic storm, and an adrenal crisis.
One more point I'll add in this tumor, and sometimes you will rarely see pituitary adenomas, or there is space occupying lesion in the brain between the hypothalamus regions and we instantly some patient will have fevers because directly it will be disturbing the cycle of the fever condition. So we rarely see in the neurosurgery side pituitary adenomas, hypothalamus, space of pain lesions. They will have present with headache and body pain also. That also
especially the apoplexy. I think especially the apoplexy, they might have fever rather than just a tumor. But I think if the pituitary apoplexy, you're right, sir, that they can get fever. Pituitary apoplexy can.
So what about hypothalamic and pituitary disease, sir?
No, hypothalamic set, but it's not classically endocrine. I mean, we are talking about pituitary, of course, can cause pituitary apoplexy. Hypothalamic tumors can cause, but can cause fever definitely because hypothalamus is involved in temperature control.
Post-pituitary Sheehan syndrome, in the past used to be described. Now it's rare. Hypothalamic being a set point, the head injuries, tumors in the brain, or hypothalamic insufficiency, one of the rare causes of CNS causes.
That is a central fever.
Agreed, sir. Dr. Narasimlu, sir, you are perfectly right. I think Dr. Hegde has not touched upon that because therefore discussed in the cancers and endocrine causes. When we usually talk of the causes that usually he has covered. But yes, you are very right because Sheehan's was at times does present as PO, and also a whole lot of adenomas, etc., pituitary adenomas, etc., can present. Not because of the thermoregulatory center, but because they are, yes, oncologic scenarios, and Dr. Shaila already touched upon it, why actually they present as fevers. So any other person, any panelist wants to add anything? Or Dr. Banjula, do we have any questions for the panel in the chat box? Dr. Narasimlu, sir, your comments on any other topic?
I want to add that in the central fever, there should be, we remember that in ischemia infarct, there is no drug, there is no fever. It is only the hemorrhage which causes fever.
Hemorrhage. Yes, very right. Very rightly pointed out. Hemorrhage can result in fever, and that is because of a lot of blood that comes out against cytokine release and inflammation that is caused by it. But thrombosis will result, but not the infarction that is causing intracerebral. Yes, unless until it is part of vasculitis.
Anupam, I would like to add about autoimmune disease fever. Classically, most common is lupus fever. And systemic onset adult Still's disease. In children, systemic onset GRA, most common. And multifocal osteomyelitis. And that's also very common. And Sjogren syndrome. They can present as a fever. And autoimmune lymphadenitis or lupus or Kikuchi lymphadenitis. Autoimmune hepatitis, autoimmune ophiritis, they all causes. And vasculitis, rheumatoid arthritis, and psoriatic arthritis, whenever there is fever, we have to suspect infection. And drugs in rheumatology, methotrexate, sulfasalazine, and tofacitinib, JAK inhibitors, can cause fever.
True.
And this is the way we approach. An approach of autoimmune disease, central causes and peripheral causes. In the peripheral, endogenous pyrogens, exogenous pyrogens. That way, very classically, we approach it. Exogenous pyrogens usually infections. Endogenous usually endogenous usually autoimmune comes and other non-infective causes. Exogenous either pyrogens like IV fluids or infections. This is the way we approach rheumatology.
But you are absolutely right. There's a whole lot of list, and you have rightly enumerated a whole lot of causes. We just touched upon it in the autoimmune diseases and connective tissue diseases segment. We just touched a glimpse was given because obviously it was not possible to discuss all this because yes, to add to it, superficial artery, temporal arteritis and Wegener's and all those things will definitely present. But probably they will have some or the other localizing sign. We concentrated upon patients who will present to us with an undifferentiated type of fever, which will actually have a non-infective cause. So that was the main crux of it. But yes, Dr. Narasimlu, sir, you have absolutely enumerated the things which we should look up. That is why actually, in case you do not find a cause, earlier we used to be asking for a liver biopsy. But yes, as one of the panelists said, nowadays people get worked up. They get a CT, chest and abdomen, and then they come. But yes, if you have lymph nodes, Kikuchis will just come definitely. And it is common also. Similarly, Takayasu also. But yes, that will depend upon what actually patient's perspective is. and we will have to actually individualize in every patient. So perfectly taken, and thank you to all the panelists. If we have any other queries, Dr. Manjula, we
No,
can pose before we close.
not here, not now.
Oh,
No.
thank you, Dr. Narsimlu sir, also everybody here and all the delegates also, and thank you, Chair, for
so
the
much.
panelists.
Thank you, Anupam.
Thank you, everybody.
Thank you for having me. Thanks. Bye-bye.
Thank you for joining from US, Dr. Shaila. Thank you, Dr. Shankar, Dr. Hegde, Dr. Chaudhary, sir. Thank you.
Thank you, Dr. Prakash, for moderating it
Good
so well.
night.
Thank you.
Thank you all.
Right.
Thank you all, panelists and Manjula ji.
And
Thank
best
you
wishes
very
for
much.
India tomorrow.
Yes.
See you, sir.
Yeah.
Thank
Good
you.
night.
Thank you very much. It was really wonderful, and a lot of things came out. Thank you, Dr. Anupam sir, and Dr. Anirban Chaudhary sir, Dr. Ashish Hegde sir, Dr. Shankar sir, and Dr. Salima for joining in from there. Thank you all very much. And so I think that was the last session. Dr. Narasimhan sir, please, can you
Yeah.
sign up
Thank
for
you.
today's session? Then before we go, sir, can you submit for the sessions of today? Before we close the sessions, since you are there from the beginning, can you give
I'm there in the beginning.
summary of the day's proceedings?
Yeah. Who has to tell me?
Yes, sir.
Oh, okay. Just 1 minute. I'll see the program. I'm there in the beginning, but only physicians hall. Right from the beginning. Just I take the names. The talk of fungal infections so good, but so many questions were there.
Yeah.
Abdul for couldn't go, but it was so excellent. Excellent. And next, emerging, re-emerging infections, so Anup Kumar also very good, and a lot of learning was there. Then fever in emergency, Rajesh Chola also well taken, and most interesting, the panel discussion was very good, especially the central causes, peripheral causes, autoimmune causes, malignancy. Malignancy we didn't cover so well. Drug fever, I think, is to require more focusing and elaboration. Because some common drugs in the practice is causing fever, like phenytoin sodium, indomethacin. The common drugs, offending drugs, cause of fever that might have been covered. But overall, it is good learning, and all the speakers, a chairperson, done excellent work. And on behalf of the Micro and behalf of the Fever Foundation, thank all of them, and also Manjula. Dynamic, active from beginning, and in the end also same dynamism. Great, Manjulaji. And also people in the background, Praveen also sitting continuously, not leaving anything. And thanks, last one and all. Thank you.
Thank you. Thank you, everyone. Mr. Raja, would like to say anything before we close?
No, madam, I think it was second day also was really quite exciting with a lot of key insights from a lot of infectious specialty. I think that would have created a lot of awareness for all our delegates. So thank you very much for taking us through the entire day. And Dr. Narasimhan, thank you very much, sir, for once again being with us throughout the day. I think Dr. Ravi also had been there as chairperson, chairing Dr. Sekhar Chakravarti, and as well as Dr. Anupam Prakash. They also have made the entire the chairing the sessions very nicely. So thank you once again, one and all of you, and good night, ma'am. Yeah.
Thank you, Dr. Shankar sir. So with your permission, we'll close day 2 session. And tomorrow, all the participants, I would like to inform. Tomorrow we are having morning session, and we are starting morning at 9 o'clock with a very, very important session, breakfast session, which is mastering the diagnostic, the clinician dilemma. We have 2 very eminent speakers, Dr. Suresh Kumar, the infectious disease specialist, and the Bhaskar Shane from the pediatrics. So it will be a common hall for both internal medicine, and from 9 to 10:30. 10:30 onwards, again, we split separately into pediatricians hall and the internal, and then we ensure that we close before the World Cup final starts. That is the agenda. So please join in tomorrow. Thanks for joining in today. Good night all.
At least 10-15 minutes before the World Cup.
Yes, sir. Thank you, sir.
Thank you.
Next event, You can stop live streaming. Only physician part. Pediatrician continue.
Recording stopped.